Hi everyone, welcome to today's quarantine clinic. We'll be taking cranial nerve examination today. Cranial nerve examination is actually quite a big subject, and if you go into any one of the cranial nerves into any sort of depth, that itself will take 1 hour each. So the purpose of today's clinic is not to give you a like an in-depth view of each and every cranial nerve, because each one of them deserves a sort of a lecture in itself. But I wanted to give you an overview of how you would approach a patient who has any single cranial nerve abnormality or multiple cranial nerve abnormality, and how will you quickly evaluate by history, and how will you quickly examine the patient. Okay, so uh, when we discuss cranial nerves, of course, the most important thing to do is to know what are the cranial nerves. So the cranial nerves in order are olfactory, optic, oculomotor, trochlear, trigeminal, and abducens. Now, in this, we usually take abducens along with uh, your oculomotor and trochlear. So usually we try to remember these three, uh, oculomotor, trochlear, and abducens as one group, and trigeminal after that. And then your seventh is facial, this auditory, ninth is glossopharyngeal, 10th is vagus, 11th is spinal accessory, and 12th is hypoglossal. So these are the cranial nerves, and anatomically, they will all arise from the brainstem. Okay, so and they all arise sequentially. That is why they are numbered like that. So your olfactory nerve arises directly from the brain itself. So it arises somewhere from the rhombencephalon. Your optic nerve also arises from the bottom of the brain, and so these two are not from the brainstem. So your cranial nerve 1 and cranial nerve 2 are not from your brainstem. After that, everything else is from your brainstem. So if we are to color the brainstem, and we say that this is the midbrain in gray, and this is the pons in brown, and say this is the medulla, then your third cranial nerve, that is oculomotor, will arise from the midbrain. Your fourth cranial nerve, that is trochlear, will arise from the midbrain. Your fifth cranial nerve, which is your trigeminal, will arise somewhere between the midbrain and the pons, so the upper part of pons. Then your sixth and seventh, they'll both arise from the pons. So this is the sixth and this is the seventh. And your eighth, ninth, eighth, eighth, 9, 10, 11, 12. They'll all arise from the medulla. Okay, so that is how there is a sequential sort of numbering from top to bottom. Now, there are certain things that you can remember. One is that your midbrain has mainly 3 and 4. Second is that your sixth and seventh, that is your abducens and your facial nerve, are both in the pontomedullary junction. So you can sort of remember that they are at this junction between your pons and your medulla. And your fifth cranial nerve, while I said that it is in the pons, but the fifth cranial nerve actually arises from four different nuclei, and they are spread out across a big area. So your fifth cranial nerve nucleus is spread out all the way from your pons up to your high cervical cord. So we will discuss this a little while later, but these are some of the pointers as to where these nerves come out of. Now, right from this point, you can guess why this is important. So, for example, if there is a medullary lesion, then we are automatically thinking about the lesions involving your lower cranial nerves. So if there is a patient who comes with involvement of your lower cranial nerves, that is from seventh downwards, so facial, then you have your vagus, your glossopharyngeal, your hypoglossal, so then that is a lower cranial nerve pathology. So you can think that it could be a medullary lesion. And if a patient comes with say your eye involvement, that means that it could be a third cranial nerve or a fourth cranial nerve involvement, or a sixth cranial nerve. So then you are thinking more of an upper brainstem or a midbrain involvement. So this anatomical distribution is important to remember. Now we will get to each cranial nerve one by one. And I'm just going to spend less than 5 minutes on each cranial nerve, just to give you an idea of how to approach the examination of each nerve. So first is olfactory. Now, certain things about the olfactory nerve. It is considered to be a direct extension of the rhombencephalon. So it's not considered to be sort of a true cranial nerve. It is almost like an extension of your rhombencephalon. There are other things that separate the olfactory nerve from your other cranial nerves. One is that the olfactory nerve enters ipsilateral. So it supplies ipsilaterally. Whereas all the other cranial nerves, your right side cranial nerve will end up in the left side of the brain. But in your olfactory nerve, what you smell from your right nose will end up in the right side of the brain, and the left will end up in the left. And there is a reason for this, but we won't get into that. But this is one of the differentiating factors of olfactory versus your the other cranial nerves. Another differentiating factor is that your olfactory nerve does not go through thalamus. Now, I've referred to this multiple times before, how thalamus is like a traffic cop, and all the sensations that the thalamus gets, it is responsible for guiding each sensation into its appropriate area. But the olfactory nerve does not go through the thalamus. It directly enters into the cortical regions where it is supposed to go. So these are a couple of important things why the olfactory nerve is not like the others. So it is ipsilateral and it doesn't go through thalamus. So that means that there is no second order neuron. No second order neuron. Now, regarding examination, no, first of all, regarding clinically, when will you suspect, or when will you try to examine a olfactory nerve? So obviously there are certain diseases in which you are suspecting your olfactory nerve to be involved. That is when you will test it. You don't need to test olfactory nerve in every patient who comes to you. If you just ask the patient that, is your sense of smell all right, and the patient says yes, then you, like COVID-19. Yes. So COVID-19 is now it is supposed to be one of the sensitive questions to ask about COVID-19, because your sensation of taste and smell is involved. But that, I think, has more to do with your upper respiratory tract involvement rather than the nerve itself. But in your general population, every patient you get, you don't have to do a detailed olfactory nerve examination. But in your exam, you do have to do it, because It is one of the favorite questions that examiners have because they know that you will miss it. So checking if you have tested for your olfactory nerve is one of the favorite questions. So you need to do it in your exams. And the way to do it, and when will you, which are the cases where you will specifically do it? One is any head trauma. So any head trauma, any facial trauma, you will do it. Any CSF leak. So if sometimes after head trauma, if there's a facial bone fracture or sphenoidal bone fracture, you could have CSF leaking. So otorrhea, CSF otorrhea or CSF rhinorrhea. And in those cases, you need to check for your olfactory nerve. And there are certain degenerative conditions. Now, this is neurologically speaking, this is one of the most important causes because degenerative conditions such as Alzheimer's or Parkinson's disease. These conditions will, it has been found that one of the earliest pathological changes in Parkinson's disease is loss of smell, and that can precede your motor problems by many years. So if you do if you are suspecting a patient of Parkinson's and you do olfactory nerve testing, you may be able to catch it pretty early. So that is why it is important to do it. Now, how do you do it? How to test? Now, step one is to check for patency. So you check for patency of your nostrils. So you close each nostril, put a cotton fiber in front of the nostril, and you ask the patient to breathe, and you see if it moves. And if it's moving, then at least your patency is normal. And next you check for each side individually. So you close each nostril and you test the sensation of smell in each side individually. The patient should not see what you are putting in front of the nose. So your eyes must be closed, and it should be a familiar smell that the patient knows. And he should be able to identify, and you should use different smells for each nostril. So that is about it. That's about the olfactory nerve. Coming to the second nerve, that is optic nerve. Now, optic nerve, I'm going to spend a little bit more time than olfactory because it is involved in so many more cases, and you need to have a good idea about optic nerve. So the basic scheme of testing your optic nerve is you need to check for visual acuity, you need to check for color vision, you need to check for field of vision, and you need to check for fundus. And finally, you need to check for reflexes. And the reason reflexes is done in the end is because reflexes carries this examination forward to the next nerve, which is third nerve, because all your reflexes are a mixture of both second nerve and third nerve. So that is why you do reflexes in the end, and it is a sort of a way to bridge examination between your optic and your oculomotor. So reflexes will take in the end. Now coming to acuity, color, field, and fundus examination. How do you test for acuity? You check with Snellen's chart. Now there is a rough way to do it and a fine way to do it. A rough way to do it would be you have to test each eye individually. So acuity is always checked with one eye closed, and you check for simple finger counting and finger movement at varying distances, and that is a rough way to check. And Snellen's chart is a more accurate way to check. Ideally, it should be at 6 feet, but you also have a handheld Snellen's chart that you can test at 2 meters. And that is something that you can print out or you can buy a handheld Snellen's chart. It is actually very useful. So if you can prepare a neurological examination kit, that is something that we might discuss another day. What all things should be there in your neuro kit? So I think I will take one small half an hour clinic on that, just how to prepare your neurokit. But one of the things that should be in your neurokit is a handheld Snellen's chart. Second, in color, you can, again, roughly, you can just ask for, you test each eye individually. You ask the patient to identify different colors around you. And if you want to be specific, then there is colored wool. So there are different yarns of wool of different colors, and you check with Ishihara's chart. Now, this is to find out if the patient can identify between different colors. There is also something known as color desaturation. So what this means is that, and this is one of the earliest signs of optic neuritis. And what this means is that the patient may be able to identify between red and green. So we would think that his color vision is normal, but inside red, if you check for different shades of red, then the patient may not be able to identify between the different shades, and he would think that all of them are the same shade. So that means that his ability to differentiate saturation of colors is gone, and that is one of the early signs of optic neuritis. So that is about color. Then coming to field. In field of vision, there are two basic things to check. One is Hemi Neglect. So what Hemi Neglect means is Hemifield and Hemi Neglect, they are two different things. So this I will just explain to you a little separately. So suppose these are your eyes. So this is the right eye and this is the left eye. Okay. Now, if say you are seeing an image, okay, so sorry, so then this should be the left eye if you're looking at it from above. Okay, now if you're seeing an image coming in from here, then what happens is this image will fall on the retina, correct? And this image will get carried in the optic nerve, and some of it will get sent to the opposite side. So I hope you're all aware of the way optic nerve, the anatomy of the optic nerve. If you're not, then tell me. I'll take another 5 minutes to explain that, because you need to know that. But in each eye, there is the concept of a field. So if there's a person here, then for this person, this entire thing is the field of vision. So everything from this side to this side is the field of vision. But within the field of vision, there are two eyes, and in each eye, it doesn't cover the whole field. So the right eye will cover, say, this much, and the left eye will cover this much. So what this means is that there is a place in the center where both the fields will overlap, but in the extremes, there are fields that are independent to each eye. So this left field will only be seen by the left eye, and the right field will only be seen by the right eye. Okay, and the reason for this is that, now suppose coming back to here, all the images that come on this side of the field, they will fall, coming from here, they will fall on the retina on the nasal side. So this is the temporal side of the field, and this is the nasal side of the retina. And all the images on the nasal side of the retina will come through the optic nerve and cross over to the other side. Whereas all the images coming in from the nasal side of the field will fall on the temporal retina, and this will go to the same side. Okay, so, and the reason for this is that for the brain wants to know everything that is happening on the right side of the field. It wants it to go to the left side of the brain, and whatever is happening on the left side of the field, it wants it to go to the right side of the brain. So this is the basic concept, and that is why there is a crossover. Now, when we say that there is a field defect, so that could mean that if a person is seeing something in front of him, he is actually seeing two fields, so one in each eye. And if there is a field defect in the right side, then that would mean that there is a field defect in the right side of both the eyes. And this, if there is a field defect in the right side of both the eyes, then that means that the defect is somewhere on this side of the brain. So if there is a right hemifield defect, then the lesion would be on the left brain. And if there is a left hemifield defect, the lesion would be in the right brain, because the field images cross over to the opposite side. Is this clear, or should I explain this again? Are you all comfortable with this concept? Because if you are, then I'll go on to explain about Hemi Neglect. If your field concept is not clear, then the neglect concept is a little bit more difficult to understand. All right. Okay, I'll just repeat it again. Okay, let's take a person. Okay, so this is his eyes, and this is the nose, and he is looking straight ahead, and this is his brain. Fine. This is the right side, and this is the left side. Now, for this person, this is the entire field of vision. And when you are looking in front, you can see the entire world as one unobstructed sheet of vision, right? Like you can see everything as one. But the reason you are able to see this is because your brain puts it together. But actually, all the images from this side, from the right side, which is known as the right hemifield. So basically, the right side of your world, everything from this part is ending up in your left occipital lobe. Left occipital lobe. Okay. And the reason that it is ending up is because everything from this, your right hemifield, all the images, the optic nerve is carrying it from the right to the left. Okay, clear so far? And every image in your left hemifield is being carried by the left optic nerve to the right occipital lobe. Okay, so if there is a if there is a lesion in the right occipital lobe. Okay, so if there is a lesion here, then that means that the person will not be able to see anything here. So he will be blind on the left hemifield, but the right hemifield will be fine. He will be able to see everything on the right side, but he won't be able to see anything on the left side because the right occipital lobe is gone. Okay, and suppose the occipital lobe is spared, but the right, if this optic nerve that is coming from here, if there is a lesion here or here or here or here, the effect would be the same. The effect would be that the left hemifield would be involved. So the hemifield is only the temporal area of the field of vision. So when I say temporal, suppose you close one eye. Okay, suppose you close one eye. What can you see? Maximum of what you can see will be in the temporal side, that is away from the midline, because that is what you'll be able to see the most, whatever is straight ahead and whatever is in the temporal side. And you will be able to see some parts of the nasal side, okay, and some above and below, but maximum you will be able to see on your temporal side. And similarly for both your eyes. So each eye will have some temporal vision, some nasal vision that is in the center, but maximum will be temporal. And the center part, both your eyes will have an overlap. Okay, is that clear? So your central bit, so I'll draw it here again. So your central bit has an overlap. Okay, so which is why we focus on the temporal fields of vision, because that is specific to one side. So then if there is a defect there, we are able to localize the lesion a lot easier. Okay, cool. Now, when we say we are testing the field of optic nerve, what does that mean? What we are basically checking is, if you close one eye, now suppose I'm going to draw the field of vision. I'm going to draw, suppose you close your left eye and you are seeing from your right eye, then everything you are seeing is the field of vision from your right eye. Now suppose this is your world that you are seeing with your right eye. Okay, and in this world that you're seeing with your right eye, this much is sort of nasal and this is temporal. Okay, but for convenience sake, we'll draw a line in the middle. Fine, is this clear? So when you close one eye, everything that, suppose you draw a midline of everything you see, whatever you see in the nasal aspect of it is nasal, and whatever you see in the temporal aspect of it is temporal. Cool. Now imagine, now this we are talking about the field. Okay, so this is the field of vision. So whatever is there in the world. Now, if you are unable to see anything from this side of the world, that is the temporal side, then the lesion can be anywhere from your retina. So suppose this is your eye and this is the field. So this is the field and this is your eye. Okay, this temporal field, the light fibers, the light rays will end up in this side of the retina, that is the nasal side of the retina. So if there is a lesion here, then this will go. Or if there is a lesion anywhere further down in the optic nerve. Okay. So when we are testing for field of vision, we are basically trying to see, we don't care about anything that is behind. All we want to see is in the field, where is the lesion? That's it. After that, once we have tested both the eyes, so in literally when we test the field, this is how we document it. We draw both the eyes, we draw a line. Okay, and we say this is the left eye and this is the right eye, and this is the temporal of both, and this is nasal of both. And then we actually black out the parts where the person is not able to see. So supposing he is not able to see on the temporal aspect of the right eye and the nasal aspect of the left eye, we say that he can't see in the temporal aspect of the right eye and the nasal aspect of the left eye. And we leave it. All we have to do when we are examining is to document the things. Then later on, you can assess it and put it together and then decide where is the lesion. But when we are examining the field, this is what we want to know. What if the lesion is not temporal and nasal? What if the lesion is bitemporal? That means that it is a temporal lesion on both sides. So there is a temporal lesion here and a temporal lesion here. Then the site of the lesion will be different. What if it is not a complete field? What if it is only a quadrantanopia? So that is, there is a temporal lesion, but only in the upper half. And similarly, on the other side, there is a nasal lesion, but only on the upper half. Then what? So each one of these different types of field defects will have a different cause. And for that, you need to know this. You need to know the anatomy of the optic nerve really well, because there are different, suppose there is a lesion here, then there'll be a different field of defect. Suppose there'll be a lesion here, then it'll be a different field of field defect. So anywhere where there is a lesion, depending on which nerve fibers that lesion is compressing, there will be a field defect. That is why examining the field properly is very, very important. Okay. I can't go deeper than this right now, but if you have any doubt, then ask me later. I'll explain it to you separately. Now, coming to hemifield. Now, what is hemifield? Coming to hemi neglect. Okay. Now, this is, I'm drawing the brain. In your brain, there is the parietal lobe. Okay. Now, the parietal lobe is responsible for three-dimensional spatial awareness. Correct? We have covered this multiple times before. Now, what if there is a lesion in the right parietal lobe? Okay, so there is a lesion here. Now, what happens is, we discussed this yesterday in our higher mental function. If there is a right parietal lobe lesion, the parietal lobe will simply start ignoring three-dimensional space on the opposite side. So if there's a right parietal lobe lesion, for this person, the left side of the world doesn't exist. Okay. And part of this not existing is that he will not be able to see anything on the left side, not because there is anything wrong in the optic nerve or the occipital lobe, but for him, the left side of the world is no longer there because he's not even aware of the left side of the world. Okay, so this is hemi neglect, and this is different from hemi anopia. So basically, if a person ignores a visual image on one side, it could be either Hemi Neglect or Hemi Anopia. Hemi Anopia is can't see, and Hemi Neglect is sort of like won't see. Okay. So in hemianopia, there is some defect in the actual optic, the pathway of the visual image from the eye to the occipital lobe. Somewhere, if there is a lesion, then it is hemianopia. And if that lesion is okay, if that tract is okay, but he's still not able to see it, then it is likely to be hemi neglect. So he's refusing to see. He won't see because for him that side of the world doesn't exist. So that is hemi neglect. Okay, now how do you test it? Hemi neglect, you test by asking the patient to keep both eyes open, and you wave your fingers on both sides. And in a mild case of hemi neglect, if you wave only one finger, if you wave the finger on only one side, he'll be able to see it on both sides. But if you wave it together, so if you move both your fingers together, you have something called sensory extinction. So he will ignore one side of the field. He'll ignore one side in favor of the other. So he's not able to balance both of them together. So he'll just pick his favorite one, and whichever side is damaged, on the opposite side, he'll ignore it. So that is called sensory extinction, and that is a sign of hemi neglect. Whereas in a hemianopia, whatever you do, he won't be able to see on the affected side. Now, finally, coming to fundus. Now, fundus examination, there's not a lot that I can teach you online, but the basic concepts are that when you look into the eye, what you are trying to see is the first thing you see will be nothing, because the first time you look into somebody's eye with a funduscope, you won't be able to see anything. But gradually, as you adjust to it, you'll start seeing the retina and you'll start seeing blood vessels. And there'll be some thick blood vessels and some thin blood vessels, some capillaries. And then gradually, you will see something like a disc. And you'll notice that all the blood vessels are sort of emerging from there. And what you want to see is the margin of this disc. Okay. And usually there will be a nice margin. And if this margin is gone, then we say it is papilledema. Okay. So this is what we want to see. There are other things that we look for. Say you look for diabetic changes, hypertensive changes. So all the cotton wool spots and flame-shaped hemorrhages. So all those things will be around in the retina here. And yeah, so those are all the changes that you can see in the fundus. But so you look for disc margin, you just look for disc edema, you can look for disc pallor. So your disc will be very pale, which you won't know until you have seen enough eyes to know what is a pale disc and what is a normal disc. So you just have to keep seeing it, and then gradually you'll start seeing all the other retinal changes. So that completes your optic nerve. Now coming on to optic reflexes. Okay, so it's already 7:38 and I haven't even covered 2 cranial nerves. This is what I was afraid of. Your main 3 optic reflexes are your light reflex, consensual light reflex, and your accommodation reflex. And there's also something called as RAPD. Now, basic concept of the light reflex is that in your eye, when there is light that is shown into one eye, so the optic nerve carries that image to the occipital lobe. But along with this, there is another tract that goes with the optic nerve and enters into your midbrain. And it goes on to both sides. And this carries the information of whether there is is there light or not? And this is much more primitive. Okay, so before we want to know what we are seeing, much before that, we want to know whether is there any light in front of us or not. So this is the information that these fibers carry, and they carry this information to this area in the midbrain known as pretectal nucleus. And there is one on both sides, and both of these pretectal nuclei are talking to each other. Okay, and right in front of the pretectal nuclei are your cranial nerve 3, that is your oculomotor nuclei, and your pretectal nuclei are talking to your oculomotor nuclei on both sides. Fine. And from your oculomotor nuclei, there is your oculomotor nerve, and this enters your eye and acts on your ciliary muscles and causes constriction. So it causes your pupils to constrict, and this is your light reflex. Now, consensual reflex happens because, like I said, it goes to both sides. So if there is light here, there is the light information will go down to the same side, act on the same side pretectal nucleus, act on the same side cranial nerve 3, and come back on the same side oculomotor nerve. But it will also go to the opposite side, act on the opposite pretectal nucleus, opposite cranial nerve 3, and act on the opposite eye also. So as soon as there is light here, there is constriction on both sides. So this is your consensual light reflex. Now, your accommodation reflex is basically when you are looking straight ahead, your pupils are not constricted, but when you make them converge, so when you look towards your nose or when you look at something very close by, there is accommodation. So accommodation meaning that you have your lens inside, so they relax. And because of that, the zonules relax, so then the lens curvature increases. So because now the image is very close by, you want that image to get the angle of the image to fall properly onto the retina. So then that lens curvature increases. So that is the accommodation reflex, and this is entirely cranial nerve 3. This has nothing to do with optic nerve, because both when you are converging your eyes, when you are moving them closer to each other, on both sides your medial rectus muscles are acting. And if you remember from yesterday, your medial rectus muscles, your cranial nerve 3 is responsible for your medial rectus muscles. And RAPD stands for relative afferent pupillary defect. And what this means is that, supposing you have 2 eyes and 2 optic nerves. Now suppose one of your optic nerve is slightly damaged, so say 25% damage. Okay, so if I show light into this eye, this will constrict and this will constrict, because this will constrict because light reflex optic nerve will take it down, and the oculomotor nerve will take it back, and the oculomotor nerve on the other side will bring it here. Now, if I show the light here, the same thing should happen. The optic nerve will take it down and the oculomotor should bring it back, and it should bring the return impulse to this eye as well. But if I keep swinging it back and forth, gradually this nerve will get fatigued. And now, depending on how much damage there is, gradually this nerve will not be able to take this reflex down. And if I am constantly looking at this eye, if the light is showing here, then it will constrict. But if the light is showing on the diseased eye, this will stop constricting and it may dilate because this optic nerve is damaged. Okay, so that is the concept of RAPD. It is also called as swinging light reflex. Okay, fine. Now I'm moving on to oculomotor nerve. I don't think we can complete all the cranial nerves today. So we don't take oculomotor nerve in isolation. We take all 3, 4, and 6 nerves together and we check for extraocular movement. Okay. Now, what are the extraocular movements that you will check? The first one that you check is pursuit. So what you do is, so this is the eye and they're looking like this. You hold up one finger and you take the finger to all directions and you take it in a H-shaped movement. So if this is the eye, then you take it in an H-shaped movement all across. Now, what all are you checking with this? You are checking you're checking range of movement. So are both the eyes able to move into all 4 quadrants? Okay. So extreme left, extreme right, up and down. So you go up and down here also, and in all 4 quadrants. Okay. And if you remember our earlier diagram of all the eye movements, so this is your medial rectus, superior rectus, inferior oblique, superior oblique, and lateral rectus. If you remember those eye movements, then we are actually checking these eye movements in all 4 quadrants. And at any point, if you think that the patient's eyes are not moving properly, then depending on that direction, you are able to see which muscle might be the problem and therefore which nerve might be the problem. Okay. And another thing you are checking is pursuit. And pursuit also we covered, if you remember, if it is not a problem with the muscle or the nerve, then maybe it might be a problem with the circuitry inside. And what is that circuitry? It is from your frontal eye field to your superior colliculus to your brainstem to your PPRF 6 nerve across to the medial longitudinal fasciculus to your cranial nerve 3. Now that circuitry is important in your eye movement, and in pursuit you also have your cerebellum. So anywhere if in this circuitry there is a problem, then your pursuit is gone. So when you check for the H-shaped movement, you are checking both extraocular movement and pursuit. Then you check something called as saccades. So saccades is basically when you want to check a rapid eye movement. So you hold up one pen here and you hold up your finger here. And you ask the patient to look at the pen and then quickly snap the eyes to look at the finger. And what you want to see is that movement smooth or did it break in the middle? So was it broken? And did it stop exactly at the right place, or did it overshoot? Or did it undershoot? So did it stop here, or did it go till here? Or did it stop exactly where it is supposed to? And if it overshot or undershot it, then it is probably a problem with the cerebellum. And check out the cerebellum clinic if you have not. Then that will give you a better idea as to why it overshoots and undershoots. And finally, you have your accommodation reflex, which we have already tested. So that covers your 3, 4th, and 6th. Now coming to trigeminal. If there's any doubt or any question, please ask in the chat and I will cover it. We can take the rest of it in the next clinic also, so there's nothing like that. Yeah. Now, trigeminal is a sensory plus motor nerve, and therefore we check for all three. So we check for motor, we check for sensory, and we check for reflex. Now, motor is basically a movements of the jaw. So the muscles that your trigeminal nerve supplies are mainly your masseter and pterygoid. So your chewing muscles. Okay. Now, when your pterygoids act in your lateral movement of your jaw, and when both the pterygoids act together, then you are pulling the jaw up, and you can also protrude it. So you ask the patient to move the jaw from side to side, and then you move it against resistance. So your pterygoids are pushing. Okay. So your right lateral pterygoid will push the jaw to the left. Okay. So if there is a right lateral pterygoid weakness, then that would mean that your jaw will come to the right because your left pterygoid will push to the right. So this is one of the places where if there is a weakness on the right nerve, then the movement will be towards that side. Okay. Now that is your motor. Now sensory we covered it briefly, I think, during Bhavesh's case presentation, but I'll just cover it again. There are two aspects to the sensory examination. One is nerve wise. So trigeminal nerve is composed of three aspects, three subtypes. So that is ophthalmic, maxillary, and mandibular. And that is V1, V2, V3. Now, if this is the eye, and this is the nose, and this is the mouth, then V1 is somewhere till here. V2 is till the angle of the mouth, and V3 is this area. Okay. So V1, V2, V3. Now, what we do is we check for pain. So that is pinprick, temperature, and fine touch. Fine touch is with the cotton. And you compare all of it with the neck. Okay. So we, for a reference point, we touch the neck and then ask the patient to compare on both sides in all the three nerve distributions. So that you are comparing V1 on both sides, V2 on both sides, V3 on both sides. And another form of testing is from center to periphery. And the reason we test it like this is because your trigeminal nerve, the way it supplies, the part of the trigeminal nerve that supplies the center of the face arises from a different part of the brainstem. So if this is the brainstem, in your trigeminal nerve nucleus, it extends from all the way from the lower part of the midbrain to the cervical cord, and the part of the the part of the trigeminal nerve nucleus that supplies the outer part of the face arises from the lower aspect, and the part of the trigeminal nerve nucleus that supplies the center of the face arises from the upper aspect. So supposing if there is a lesion in the brainstem that is going upwards, then you will have consecutively increasing sensory loss that is coming closer and closer towards the center. And this is known as onion ring or balaclava phenomenon. And finally, you have your jaw jerk and corneal reflexes. So corneal reflexes first because it is a superficial reflex, and jaw jerk is a deep tendon reflex. In a normal patient, jaw jerk is usually absent. So if you get a very classical present jaw jerk, it is a sign of UMN lesion. And UMN with jaw jerk present can be anything in your classically it is your anterior horn cell disease. Okay, so that covers your trigeminal nerve. Now coming to facial. Facial, also motor and sensory. Motor are your muscles of facial expression. And in this, you need to divide the face into two, and you have to check for expressions around the eyes. So you look at eye movement. First, you look at the frontalis muscle and you ask the patient to lift the eyebrows. And second is to close the eyes. Okay. And then you move to the lower part of the face and you ask the patient to blow cheeks and grimace. Smile. Now, these are all different facial muscles that we use. And classically, in a UMN facial nerve lesion, the upper aspect is spared on both sides, whereas only the lower aspect, the contralateral facial nerve, is involved. But if it is an LMN lesion, then the entire face is involved. Okay, and the reason is that the upper half of the face has a bilateral representation. So both sides of the brain will supply both sides of your upper half of the face, whereas in the lower half, only the opposite side is responsible for supplying the lower half of the face. And your sensory testing in facial nerve is chorda tympani, which is the taste sensation in anterior part of the tongue. This is not something that we do routinely, but important to know. Auditory, finish it off. So auditory, there are a couple of things to remember. One, you don't need to do it in every patient. Okay, so there is a gross method and a fine method. So gross method is you cover each ear and you make a small rustling sound with your finger, and you just ask if the patient is able to hear on both sides, and you ask the patient if there is any history of hearing loss or tinnitus or anything to suggest either a cochlear nerve component or a vestibular nerve component, because an auditory nerve contains both input from the cochlea and input from the vestibular system, and they are both entirely different. Now, supposing if there is no history like that, then you don't need to go ahead and do a detailed examination. But if there is a history like that, then you need to check with Weber's and Rene's test. And you use a 5 and 12 Hertz tuning fork. Okay. Now, what is Do you mind if I skip this? So basically Weber's is when you put a tuning fork in the center and you see if the hearing is localized to one side. In a normal patient, it will be heard in both sides equally. But in an abnormal, if there is one ear which is abnormal, it it might get localized there if there is conductive, and it will get localized to the opposite side if there is a sensory. And with Renes, you are checking for air conduction and bone conduction. Usually air conduction is more than bone conduction. But if there is a conductive hearing loss, then bone conduction is more. So if you can combine both of this, then you can diagnose which ear is the problem, first of all, and whether it is a sensory neural hearing loss or a conductive hearing loss. Then coming to cranial nerve 9 and 10, we usually check both of this together. Karthik has asked for clinical bedside test for vestibular component. Sure. So vestibular tests, basically what does the vestibular system do? Vestibular system maintains balance, right? So if there is a patient, the vestibular system contains these semicircular canals on both sides, and it is like a XYZ axis kind of a thing, where using fluid that keeps traveling down these semicircular canals, we are judging if the head is facing upwards or tilted to one side, or is it continuously moving. So it's, have you seen that tool that workmen use to see if there is a table which is perfectly level or is it slightly tilted? So there is an air bubble that moves, and if it is exactly at the center, then you know that the table is perfectly at level. So your vestibular system is something like that. So it has three of those, and as your head moves, that bubble keeps moving, and then with that information, you know where your head is facing. Okay, so that is the concept of the vestibular system. Now, as you move your head to one side, because that bubble moves the other side, the opposite vestibular system. So if your head is moving to the right, but you want to keep looking straight ahead, you need your right vestibular system to push your eyes to the left. Does that make sense? Because this is the concept of the vestibular system. If you are moving your head to the right, your right vestibular system will push your eyes to the left, because if it doesn't, then your eyes will also move with it. So one bedside test that you can do is called the head impulse test. So what the head impulse test does is, so there's a patient here, and this is the eyes, and this is the, I'm sorry, I'm making such a scary looking image, but what you do is, in the head impulse test, you'll ask the patient to keep looking straight ahead. No matter what, the patient should look straight ahead, probably at your nose. Now you move the head to the right. Okay. In a patient who doesn't have a good vestibular system, what will happen is that if the head turns to the right, so will the eyes turn to the right. Now the eyes will look to that side. But if the vestibular system is normal, now what will happen is that the patient head is turned there, but the eyes are now looking towards this side. And that is because the right vestibular system has pushed the eyes to the opposite side. And similarly to the other side. So suppose if you move the head to the left, your eyes have to be pushed to the opposite side, to the right. And if either one of this is a problem, then you can know that that side vestibular system there is something wrong. So that is defective. So this is a good bedside test to do. It is called head impulse test. Cool, Karthik? Now coming to cranial nerve 9 and 10. So this we usually test together, and 9 and 10 supplies all your palatal muscles, and sorry. So what you basically want to check is position of the uvula and palatal muscles. So if you are looking into somebody's mouth and the uvula is hanging in the center and the palatal folds are on either side, you want to check if the uvula is central or is it pushed to one side. And secondly, are the palatal folds intact, or have they fallen? So are they low hanging? So is it tensed up or is it loose? Okay, now out of these, the uvula is the more important one. You want to check if the uvula is central. And secondly, another test you can do, so this is inspection. And another test you can do is the gag reflex, which is very uncomfortable, but you need to do it if you are suspecting a cranial nerve 9 or 10 involvement or a bulbar involvement. So the bulb, when we say bulbar, what you mean is medulla, basically, or brainstem. So if there is a medullary lesion, then your cranial nerve 9 and 10 can get involved. And thirdly, you can also check for taste at the back of the tongue. Although now that concept is sort of getting outdated, that chorda tympani especially for front of the tongue and glossopharyngeal especially for back of the tongue. So now it's no longer very clear cut. And also there was the concept of different sides of the tongue will have different taste. So salt will be at the tip and sugar will be in the center, but now even that concept is a little outdated. So it's just important to know whether taste is intact or lost. So this is the thing. One concept I wanted to tell you was rule of 17. Okay, so what the rule of 17 is 10 plus 7 is equal to 17 and 12 plus 5 is equal to 17. Okay, have you heard of this, or can you guess what it is? I'll give you exactly 30 seconds. You've heard of this. Okay, can you tell me what it is, Bhavish? So are you typing, or you can just switch on your facial nerve and vagus nerve? Excellent. Okay, so this is your facial and this is your vagus, and this is your hypoglossal, this is your trigeminal. And what they say is that if there is a weakness or if there is a palsy, then in all four of these nerve palsies, there will be some movement of that affected muscle, whichever it is supplying, or that affected part of the face. Now, in facial and vagus, that movement will be towards the opposite side, and in hypoglossal and trigeminal, it will be towards the same side. Fine. Now, what does this mean? Now, your trigeminal nerve we already discussed, your jaw. So if your right trigeminal goes, then your right pterygoid will go, right lateral pterygoid, and therefore your jaw will move towards the right. So it is moving towards the same side as the palsy. Similarly, in suppose your right hypoglossal goes, then your right genioglossus muscle will go, and therefore your tongue deviates to the right. Whereas in vagus, the 10th nerve, your uvula moves towards the opposite side, and in your facial nerve, the angle of the mouth moves towards the opposite side. Okay. So in all four of these nerves, something moves. So in vagus, uvula moves. In facial, angle of mouth moves. In hypoglossus, your tongue moves. And in trigeminal, your jaw moves. But which direction does it move? So vagus and facial, it will go to the opposite side. And tongue and hypoglossus and trigeminal, it will go to the same side. So this is rule of 17. Now, coming to your sternocleidomastoid, sorry, your spinal accessory muscle, spinal accessory nerve, that is cranial nerve 11. Two muscles to be tested, sternocleidomastoid and trapezius. Trapezius is by shrugging shoulder. So you ask the patient to shrug the shoulder, you lift up the shoulder, and then you try to push it down. And if there is trapezius weakness, then you will be able to push it down. And sternocleidomastoid, you ask the patient to turn the neck side to side and front and back. Not back, sorry, just the front. You ask the patient to basically flex the neck. So when you're flexing the neck, bilateral sternocleidomastoids are acting. And if you're asking the patient to move side to side, then that ipsilateral sternocleidomastoid is acting. Okay. So yeah. Now coming to 12th, which is hypoglossus. And that is a pure motor. So there is no, even though it is supplying the tongue, there is no involvement of taste. And what you check is movement of tongue. So you check for side to side movement and protrusion. And protrusion is bilateral genioglossus action. And side to side is opposite. So your left genioglossus will push it to the right. Which is why if there is left weakness, then the movement of the tongue will be towards the same side. Okay. Yeah, I think that's about it. That is the basics of cranial nerve examination.